We'll start with the next chapter, which is immunodeficiency disorders. Immune system is the one that protects us from various diseases. If our immune system fails to function, or if it is not working properly, then we'll get some diseases, and those diseases are called as immunodeficiency disorders. Immunodeficiency disorders can be broadly classified into two types. We have primary immunodeficiency disorders and secondary immunodeficiency disorders. Primary immunodeficiency disorders are mostly inherited disorders. These are genetically determined. These disorders result from abnormalities in the development of the immune system. So, primary immunodeficiency results from any abnormality in the development of the immune system. And secondary immunodeficiency disorders, they are secondary to some diseases, or they come as a consequence of taking some drugs or nutritional inadequacies, but they are secondary to some or the other thing. But primary, it is genetically determined abnormality in the development of the immune system. So these primary immunodeficiency disorders can be again classified into few different types. So first, it can be disorders of specific immunity, where there can be a deficiency in B lymphocytes, or there can be a deficiency in T lymphocytes, or there can be a deficiency in both B cell and T cells. So that is called as combined immunodeficiency disorder. Then there can be a disorder in which complement system is affected. So there is disorders of complement deficiency. Then there is a disorder in which phagocytosis is affected. So we have disorders of phagocytosis. So we know we have two types of immunity. We have humoral immunity and we have cell-mediated immunity. So when will be humoral immunity will be affected, and when will be cell-mediated immunity will be affected? So humoral immunity will be affected when there is a problem in the production of antibodies. And antibodies are produced by plasma cells, which are nothing but B cells. So when there is B cell deficiency, humoral immunity will be affected. And cell-mediated immunity will be affected when there is T cell deficiency. So we'll start with B cell deficiency, or there is another name for it, that is humoral immunodeficiency disorder. So the first disease that we're going to see in humoral immunodeficiency disorder is X-linked A-gamma globulinemia, which is also called as Bruton's disease, because this syndrome was first described by the Bruton. So Bruton is the first one who discovered such type of immunodeficiency, which is seen only in male infants, and he discovered this in 1952. So there is a clinical case that I have written here. There is a 9-month-old infant. So this infant was brought to the hospital with symptoms of fever and difficulty in breathing. And his mother reported that he had 2 similar episodes in the last 2 months. Then he got treatment for it and sent back home. Then again in 12 months, he came with measles. So again after treatment, he got recovered, and in 18 months, it was noted that boy's height and weight were not appropriate for his age. But all these problems are seen only in him, and he has 3 more sisters who are not having any such problem, and they are having good health. Then we ran few tests on this boy, and in that test they found out immunoglobulin G is decreased so much, and immunoglobulin A and immunoglobulin M are also decreased. Then they took a biopsy of his lymph nodes. He found that there is a depletion of cells of the bursa dependent areas of the lymph node. So the first thing that we note here is this person is getting recurrent infections. So whenever a person is getting recurrent infections, the main reason that we have to think about is immunodeficiency disorder. This person is not able to fight against that bacteria or a virus, so he is getting infected. That is why he is getting recurrent infections. And the second thing that we note here is all his 3 sisters are in good health and he is the only one who is affected with such problem. So that means this disorder is X-linked. Usually in X-linked disorders, son is the only one affected and daughters are spared. So this disorder is X-linked. And one more thing that you can notice is this infant is getting affected only in 9 months. Because usually up till 6 months that infant will be breastfed, and by breastfeeding he is getting mother's antibodies. So he is having that immunity from the mother's antibody to fight against various infections. But around 6 to 9 months there is going to be a transition, because the person will start producing his own antibodies and the breastfeeding will stop eventually. So this person will have a transition from mother's antibodies to self antibodies. So around 9 months only this person will have only his self antibodies and he has to fight only with his self antibodies. That is why the infection is starting from 9 months. Then we can see there is depletion of cells of the bursa dependent areas in his lymph node. So some cells are getting depleted, and that cells, it has something to do with the production of antibodies, and we know antibodies are produced in B cells. So in this disorder, what happens is there is a defect in a gene. The gene is called as tyrosine kinase gene. So this gene is affected in this disorder. Because of this mutation, pro-B cells, they are not able to get converted into pre-B cells because of the B cell tyrosine kinase gene defect. So if pre-B cells are not produced, then the B lymphocytes are not produced properly, then B lymphocytes cannot be converted into plasma cells, so there is going to be a decrease in the production of antibodies. So that is why in this disorder we can find immunoglobulin G, A and M, they are decreased in number. So in X-linked A gamma globulinemia, there is going to be a gene defect of B cell tyrosine kinase. So this will lead to decreased production of antibodies because of the deficiency in pre-B cells. That is why we can see depletion of cells in the lymph node. And since the person is lacking humoral immunity, because the person is lacking antibody, this person will get recurrent infections, and that infections will start only after 6 months, because till 6 months that person or that infant is breastfed and he will get mother's antibodies through breast milk. So in X-linked A gamma globulinemia, there will be recurrent serious infections with many bacteria and viruses, and mostly pyogenic bacteria like pneumococci, streptococci, meningococci. And there is a general rule. Whenever you find a person or you find a child with any type of immunodeficiency, primary immunodeficiency, then the general rule is you should not give that infant live microbial vaccines. So live microbial vaccines should not be given to any children, should not be given to any child with any type of primary immunodeficiency disorder. This is because these vaccines, they will have weakened live viruses. So these weakened live viruses can be well tolerated by a person who is having good immune system. But if a person is having an immunodeficiency disorder, then that person will be affected dangerously by these weakened live viruses also. So live microbial vaccines are contraindicated in an immunocompromised person. Then the second disorder we will see is transient hypogammaglobulinemia of infancy, and this is also a humoral immunodeficiency disorder. So in transient hypogammaglobulinemia of infancy, there is abnormal delay in the initiation of immunoglobulin G synthesis in infants. So normally we will get mother's antibodies till 6 months, that is till the person is breastfed, but usually that maternal antibody is also catabolized. Then around 2 months the person will start producing his own immunoglobulin or his own antibody. So immunoglobulin G will be produced by the 2nd month of life. So if there is a delay in the synthesis of this immunoglobulin, then this person is predisposed to getting infectious disorders. So if you see in the name, there is transient. Transient means this disorder will occur only for a very less time. So there is just a delay. It is not stoppage. There is just a delay in the production of IgG synthesis. So this delay is usually around 18 months. So by 18 to 30 months age, this person will spontaneously recover from this disorder. Then the next disorder we will see is common variable immunodeficiency. It is also called as late onset hypogammaglobulinemia, because this is going to be happening in later parts of life, that is around 15 to 35 years of age. We know to produce antibodies we need plasma cells, and plasma cells are nothing but modified B cells. So in this disorder what happens is B cells cannot be transformed into plasma cells, so we can't produce antibodies. So that is the problem in common variable immunodeficiency. So that will lead to low level of total immunoglobulins, that is low level of antibodies, because we don't have plasma cells. Antibodies are produced from plasma cells. Other than this, there are also other manifestations. They are malabsorption, giardiasis, recurrent pyogenic infections, and increased incidence of autoimmune diseases. All these manifestations are seen in common variable immunodeficiency. So to treat this disease, we have to administer that patient gamma globulin preparations. We can administer them intramuscularly or intravenously. So that will correct the low level of total immunoglobulins and the patient will recover. Then the next disease we'll see is selective immunoglobulin deficiencies, which is also called as dysgammaglobulinemia. So the name says selective because in this disorder there is going to be selective deficiency of one or more immunoglobulin classes. So it can be of 3 types. It can be deficiency of IgA selectively or IgM selectively, or sometimes deficiency can be of subclasses like deficiency of IgG subclasses. And these dysgammaglobulinemias are very common and it is seen in many patients who are getting recurrent infectious disorders. And among these 3, the most common is isolated IgA deficiency. And in this patient, sometimes it is seen that there is the presence of anti-IgA antibodies which destroy immunoglobulin A. So this person will get more respiratory infections, and this person will get atopic disorders, and sometimes this person can also get steatorrhea. Then the second one we will see is selective IgM deficiency, and this deficiency is mostly associated with patients who are getting septicemia. And in deficiency of IgG subclasses, the patient is predisposed to getting chronic progressive bronchiectasis. Then the next disorder is X-linked hyper IgM syndrome. So this disorder is X-linked. Sometimes it can also be autosomal recessive. Then in this disorder, there is going to be hyper IgM, that is elevated levels of immunoglobulin M. So because of this selective elevation in the levels of IgM, there is going to be relatively low levels of immunoglobulin G and immunoglobulin A. So the manifestations which are associated with this syndrome are thrombocytopenia, neutropenia, that is decrease in the level of platelets, decrease in the level of neutrophils, and then decrease in the levels of red blood cells leading to hemolytic anemia, renal lesions, and all of these are happening due to autoimmune destruction of the cells. So there is going to be autoimmune destruction of platelets, neutrophils, and red blood cells leading to thrombocytopenia, neutropenia, and hemolytic anemia. So the last disorder that we will see in B cell disorders is transcobalamin 2 deficiency. So this transcobalamin 2 deficiency, it is inherited as autosomal recessive trait, and they are going to show effects of vitamin B12 deficiency. That is, they are going to show megaloblastic anemia and intestinal villus atrophy. But together with these two manifestations, this patient is going to be having some immunological defects, that are depleted plasma cells, and whenever plasma cells are depleted, the antibodies in the circulation will also be low. So there is going to be diminished immunoglobulin levels, and the person will also have impaired phagocytosis. So the treatment for this disorder is vitamin B12 supplementation. So the next thing we are going to see is cellular immunodeficiencies, which are nothing but T cell defects. So the first disorder that we will see in cellular immunodeficiency is DGeorge syndrome. So DGeorge syndrome, what happens is there is going to be thymic hypoplasia or aplasia. So the problem here is there is going to be defective development of the third and the fourth pharyngeal pouch derivatives. So this will cause aplasia or hypoplasia of thymus and parathyroid glands. And this defect is caused due to a chromosomal abnormality. There is a micro deletion in chromosome 22, and because of that, the development of the third and the fourth pharyngeal pouch derivatives are affected. So this will give us many manifestations, and that can be remembered by the mnemonic catch 22. So here 22 is chromosome number 22, which is a genetical defect, a chromosomal abnormality that has caused this DGeorge syndrome, and the catch here tells us about the manifestations. So C means cardiac abnormality. The most common cardiac abnormality that is associated with DGeorge syndrome is tetralogy of Fallot, but we can also see other cardiac abnormalities of heart and great vessels like transposition of great arteries. So all these can be seen in DGeorge syndrome. And the second here, A stands for abnormal phases. So in this abnormal phases, this patient can have many particular facial features like low set ears, short width of the eye openings, and even their nose will have an enlarged tip, and their upper lip is usually flattened and long face. So all these facial features are seen in the patient with DGeorge syndrome. And T here stands for thymic absence or thymic hypoplasia or aplasia, and this is the one that is going to cause deficiency of T cell. So thymic hypoplasia or aplasia are the ones which are responsible for the immunological effects of this DGeorge syndrome. Then C here stands for cleft palate, and H stands for hypocalcemia, and this is because of the parathyroid gland aplasia or hypoplasia. So the manifestations of DGeorge syndrome can be remembered by this mnemonic. So since T cell abnormality or T cell deficiency is seen in this syndrome, this is going to be responsible for the defective cell mediated immunity, but in this disorder humoral immunity is usually unaffected. Then the next disorder we will see is chronic mucocutaneous candidosis. So in this disorder, the patient is unable to give effective immune response against Candida albicans, that is the fungus that is causing candidiasis. So because of that, this person is going to get recurrent candidiasis. So you can see in this picture, this person got candidal infection on their skin, on their mucosas, and even they got in their skin of the hand and even in nails. But this person is usually not susceptible to any other infection other than candidiasis. And this is because intracellular killing of candida is defective, that is, cell mediated immunity to candida is deficient, but any other immune response is not usually affected. Then the next disorder is purine nucleoside phosphorylase deficiency. So purine nucleoside phosphorylase, it is an enzyme, and this enzyme is involved in degradation of purines to hypoxanthines and then finally to uric acid. So purine nucleoside phosphorylase, it will help in degradation of purines to hypoxanthines. So the patient who is having purine nucleoside phosphorylase deficiency, they also show decreased cell mediated immunity, and because of that this person will get recurrent or chronic infections, and this person is usually coming to us with the manifestations of hypoplastic anemia. They will also have recurrent pneumonia, they can have diarrhea, they can have candidiasis. And to diagnose this disorder, we can check the levels of serum uric acid, and in this patient serum uric acid level is usually low, and that can be useful for diagnostic purposes. So in PNP deficiency, there is a problem in degradation of purines to hypoxanthines and then hypoxanthines to uric acids. So this will give us such manifestations, and when you see low levels of uric acid in this patient, you can suspect PNP deficiency. So the next disorder that we are going to discuss is combined immunodeficiencies. So in combined immunodeficiency, we will have B cell defects also, we will have T cell defects also. So in this, the first disorder that we will see is Nezelov syndrome. This Nezelov syndrome, it's a cellular immunodeficiency with abnormal immunoglobulin synthesis. That is, here there is going to be a T cell defect, there is going to be a marked deficiency of T cell immunity, and we have seen abnormal immunoglobulin synthesis. And whenever the synthesis of immunoglobulin is affected, that means B cells are affected. So here there is going to be varying deficiency of B cell immunity also. So again, this person is predisposed to getting recurrent fungal, bacterial, viral and protozoal disorders or infections. And in this disorder, autoimmune processes like hemolytic anemia, they are also very common. Next disorder we will see is ataxia telangiectasia. So in ataxia telangiectasia, we are going to have three things. First one we will have is cerebellar ataxia. Then we will have telangiectasia. And the last one that we will have is ovarian dysgenesis. So in this condition, there is going to be a combined immunodeficiency, and together with that we are going to have all these three manifestations. And mostly in this combined immunodeficiency, we will have decreased levels of immunoglobulin A and immunoglobulin E. And here the cell mediated immunity is also defective. That's why this is called as combined immunodeficiency. So in ataxia telangiectasia, we will have immunodeficiency plus three other manifestations, that are cerebellar ataxia, telangiectasia and ovarian dysgenesis. And this is also a hereditary condition, and that is inherited in autosomal recessive trait. So in this picture you can see this person is having telangiectasia, which are nothing but dilated small blood vessels, and these small blood vessels are dilated on the skin or they are dilated in the mucous membrane, and it can appear in any part of the body. So they will have telangiectasia, they will also have cerebellar ataxia, and cerebellar ataxia is nothing but uncoordinated movement or balance, and this is due to damage in any part of the brain, and here the damage is present in the cerebellum. So uncoordinated movement due to cerebellar lesion is cerebellar ataxia, and this person will also have ovarian dysgenesis. So the next disorder is Wiskott-Aldrich syndrome, and Wiskott-Aldrich syndrome is a X-linked disorder. So this is also a hereditary condition which is inherited in X-linked trait. So in this disorder, there is a problem in a gene called as WASP gene. So this gene is defective in this disorder. There is going to be both cell-mediated immunity and humoral immunity that will be affected, and cell-mediated immunity is progressively affected, and this is because of the depletion of cells in the thymus and the paracortical areas of lymph nodes. So here the cells which are present in the paracortical areas of lymph nodes and thymus are depleted. And in Wiskott-Aldrich syndrome, if you talk about the humoral immunity, immunoglobulin M will be deficient, immunoglobulin E will be elevated or increased, but other immunoglobulins will be normal. So this is a characteristic feature that will be seen in Wiskott-Aldrich syndrome. So you can remember the manifestations of this Wiskott-Aldrich syndrome by this mnemonic RED. So in red, R is for recurrent infections. So they will get recurrent pneumonia and other infections in this disorder. And E stands for eczema. So you can see in this picture, this patient is having eczema. And T stands for thrombocytopenia, that is decreased number of platelets. So whenever platelets are decreased, the patient can have petechiae. So petechiae, nothing but a red, small red or purple spot. So these are nothing but pinpoint bleeding on the skin. So these red features are seen in Wiskott-Aldrich syndrome. So the next disorder is immunodeficiency that is associated with thymoma. So thymoma is nothing but a benign thymic tumor. So this benign thymic tumor, it is usually occurring in adults. So because of this tumor, there is going to be an impaired cell-mediated immunity, and there is going to be A-gamma globulinemia. And this disorder is usually associated with aplastic anemia, and this is a very rare disorder, and it is also called as Good syndrome. Disorder we will see is severe combined immunodeficiency. In severe combined immunodeficiency, there is going to be a defect in the common gamma chain of interleukin 2, 4, 7 and 9 receptors. So this disorder is also called as Swiss type A gamma globulinemia. So the most common defect in SCID is this common gamma chain in the interleukin 2, 4, 7, 9 receptor defect. And the second most common defect in this SCID is adenosine deaminase deficiency. So there can also be other defects, that is there can be a defect in RAG1 and RAG2 genes. So whenever these two genes are defective, there is going to be a total absence of T and B lymphocytes in this patient. So there is going to be a total absence of T and B lymphocytes. Or there can also be a deficiency of PNP, that is deficiency of purine nucleoside phosphorylase. So in this there are many defects that are combined and they are causing immunodeficiency. So that is why this is called a severe combined immunodeficiency. So after this we will move on to the disorders of complement system. So we have discussed the disorders of complement system in the complement system chapter. Let's talk about them briefly. Disorders of complement system can be classified into two types. There can be a complement component deficiency or there can be a complement inhibitor deficiency. So in complement component deficiency, some of the complement proteins will be deficient. For example, we have C3 deficiency, which is seen in systemic lupus erythematosus, and it is also seen in recurrent pyogenic infections. And if you take C6, C7 and C8 deficient, then the MAC complex membrane attack complex will not be formed, and this will lead to recurrent Neisseria infection. So like this, if any complement component is deficient, we can have some disorder. So that will come under complement component deficiency. Then we have complement inhibitor deficiency. So inhibitors and inactivators, these are the regulators of complement system. So we have different types of inhibitors, but for example, we'll take one inhibitor, that is C1 inhibitor. So this C1 inhibitor, if it is deficient, it will cause hereditary angioneurotic edema. So we have discussed about all the disorders of complement system in the complement system chapter. So after this, we will move on to the disorders of phagocytosis. So disorders of phagocytosis can be divided into two types. It can be an intrinsic disorder or it can be an extrinsic disorder. Intrinsic disorder means there is a problem inside the phagocytic cell. So intrinsic means within the phagocytic cell. So for example, we have enzymes which are present in the phagocytic cells that are deficient, so that the phagocytosis will not happen properly. But if you talk about extrinsic disorder, this is a problem outside the phagocytic cell. That is, there are many factors that will promote phagocytosis, and they are called as opsonins. And these factors may be deficient, and because of that, phagocytosis will not happen properly. So such disorder is called as an extrinsic disorder. So in extrinsic disorder, the problem is in factors that are present outside the phagocytic cell which promotes phagocytosis. So we will talk about few diseases which come under disorders of phagocytosis. So the first disease we will talk about is chronic granulomatous disease. So in this disease, there is a deficiency of NADPH oxidase. So because of this enzyme deficiency, NADPH oxidase, there is the decreased production in H2O2 or hydrogen peroxide. And hydrogen peroxide has a bactericidal effect. So when there is a decreased production of H2O2, the bactericidal activity of a phagocytic cell will decrease. So because of this, the patient is predisposed to getting recurrent catalase positive bacterial infections. And catalase positive bacteria, they are staphylococci and coliforms. So this disease is also a familial disorder. It has two types of inheritance. The most common type of inheritance is X-linked, and this is seen definitely in boys. And the rare type of inheritance is autosomal recessive type. So there is a test that can be used for screening of chronic granulomatous disease, and that test is called as nitroblue tetrazolium test. So this nitroblue tetrazolium test is used as a screening method for the diagnosis of chronic granulomatous disease. And in this test, what we will do is, we will see whether the leukocytes during phagocytosis can reduce nitroblue tetrazolium. And if they can reduce nitroblue tetrazolium, then the patient is not having this chronic granulomatous disease. If the patient cannot reduce this nitroblue tetrazolium during phagocytosis, then the test is positive and the patient may have chronic granulomatous disease. So this is used as a screening test for the diagnosis of this disease. And the second disease is myeloperoxidase deficiency. Myeloperoxidase is an enzyme which is involved in the production of oxygen free radicals, and when this myeloperoxidase enzyme is deficient, the patient is predisposed to getting Candida albicans infection. The second disorder, myeloperoxidase deficiency, it is very rare, and here the myeloperoxidase enzyme is deficient. Because of this, oxygen free radicals, reactive oxygen species cannot be formed. So again, the bactericidal activity of the phagocytic cell is deficient, and this is the reason the person is predisposed to Candida albicans infection. So the third disorder is Chediak-Higashi syndrome. So in Chediak-Higashi syndrome, there is a defective phagolysosomal fusion. So there is a defect in fusion of lysosome with the phagosome. So again, the bactericidal effect of the phagocytic cell is decreased, and this will lead to increased susceptibility to Staphylococcus aureus infection. So the next disorder is leukocyte G6PD deficiency. As the name says, leukocytes are deficient in glucose 6-phosphate dehydrogenase enzyme. So this disease actually resembles the chronic granulomatous disease, where NADPH oxidase enzyme is defective. But in this leukocyte G6PD deficiency, the nitro-blue tetrazolium test will be normal. So that is the differential diagnosis for leukocyte G6PD deficiency. In leukocyte G6PD deficiency, nitro-blue tetrazolium test is normal, but in chronic granulomatous disease, the nitro-blue tetrazolium test will be positive. So both will have similar features other than that. So the next disorder that we will see is Job syndrome. The pathogenesis of this syndrome is not clear, but in this syndrome there is a overstimulation and understimulation of the immune system. Here we can see immunoglobulin E is very grossly elevated, but other immunoglobulins are normal. So the most common feature that we will see in Job syndrome is formation of abscess. So there is a multiple large staphylococcal abscess. So these abscesses containing very large amount of pus, they develop repeatedly under the skin, and they also develop in various organs, and this person can also get atopic eczema, chronic nasal discharge, and otitis media. But the most common manifestation is this abscesses that will develop under the skin. And in Job syndrome, immunoglobulin E is elevated, but other immunoglobulins are normal. So till now we have discussed the primary immunodeficiency disorder, but the secondary immunodeficiency disorder, which appears secondary to some diseases or drugs, those are more common than primary immunodeficiency disorder. So secondary immunodeficiency again can be humoral deficiency or cell mediated deficiency. So in humoral deficiency, mostly there is going to be tumors or malignancies. So there is going to be a lymphoid malignancy, and because of this lymphoid malignancy, B cells are going to be depleted. So when these B cells are depleted, the immunoglobulins will also be decreased. So for example, in chronic lymphatic leukemia, which is also a lymphoid malignancy where there is going to be a depletion of B cells. So other than this, there can also be other reasons why humoral immunity is deficient. For example, there can be increased immunoglobulin catabolism. So this will happen in nephrotic syndrome. So because of this increased immunoglobulin catabolism, the immunoglobulin levels in the circulation will be decreased. Or there can be a disease where there is going to be excessive production of abnormal immunoglobulins, and that disease is nothing but multiple myeloma. So in multiple myeloma, there is going to be excessive production of immunoglobulins. Immunoglobulins will be increased, but all these immunoglobulins are abnormal in nature, so they cannot produce effective immune response. So after humoral immunodeficiency, we have cell-mediated immunodeficiency. So again in cell-mediated immunodeficiency, the T cells are depleted due to any lymphoreticular malignancies. For example, we have Hodgkin lymphoma. So this cell-mediated immunity can also be deficient in other conditions, like it can be deficient in viral infections, for example in measles, and it can be deficient in some bacterial infections which will affect the lymph nodes, that is leprosy, and sometimes the cells are produced normally but the lymph circulation is obstructed. So that can also be a reason why the T cells are deficient in the circulation. So that can be lymph circulation obstruction.